the shadow pandemic, COVID-19's impact on women in the United States, and of course, beyond. We decided to go with this topic as we saw research coming out pointing to the many ways in which this crisis is affecting women's health, livelihood, and their very survival. Now, let us go right into it with our first guest. We welcome back to our weekly calls Dr. Tung Nguyen, professor of the University of California, San Francisco, Health Division of General Internal Medicine, who will give us an update on the pandemic. Welcome, Professor.
Thanks for having me be here to give you some updates on the data and research regarding the pandemic. As usual, I'll give you the update overall. May 21st, as of yesterday, May 21st, there are over 5 million people who were diagnosed with COVID-19 and about 320,000 deaths worldwide. In the United States, there are 1.6 million infections, and today I think it's up to 95,000 deaths. The good news is that the number of new infections and deaths have plateaued or declining slightly in the United States. The bad news is that I missed the last couple of meetings. The 21 days since I last updated you, the total number of infections and deaths have increased by 50%. There are still consistently over 20,000 new cases and 1,000 deaths in the US daily. There's a new report from the Kaiser Family Foundation that showed that in 18 states, a majority of COVID-19 deaths came from residents of long-term care facilities. So that's definitely a very high-risk group. One piece of information that might be interesting to us is that there's a large, what we call meta-analysis, which is a study of a bunch of studies of 11,000 COVID patients that show that people who smoke cigarettes with COVID, who get COVID, were at twice the chance of getting the disease or having the disease getting worse. We'll focus a little bit on minority communities. There's a lot more data coming out that emphasize that the burden of COVID-19 is disproportionately on minorities. In California, there is evidence that African Americans and Latinx age 18 to 49 are dying from COVID-19 at a rate 2.5 times that of their white counterparts. What's really shocking is that more than 20,000 African Americans have died from COVID-19 for a mortality rate of 50 per 100,000 people. This means that 1 out of every 2,000 African Americans have died from COVID-19 just in the last 3 months alone, which is a staggering statistic. The similar mortality rate for Latinx is 22.9, Asian 22.7, and whites at 20.7 per 100,000 people. The Navajo Nation in Arizona, New Mexico, and Utah now has the highest infection rate for a population, higher than that the state of New York. We know the Pacific Islanders have disparities in COVID-19. And our own Asian American Research Center on Health just published a recent research brief that shows a possible mortality disparity among Asian Americans in San Francisco. Along that line, I do want to give a shout out to a website put together by some of our UCSF students that address common COVID-19 myths in English, Spanish, and 5 other Asian languages. It's COVID19factcheck.com. In the largest study examining COVID-19 outcomes to date, the medical records of 17 million adults in the United Kingdom were analyzed to assess for factors associated with deaths from COVID-19. They had 5,683 deaths in the hospital, and as with many other studies, the death risk was associated with being male, being older, and having uncontrolled diabetes. Interestingly, being poor was also a risk factor from dying from COVID-19 in the UK. And additionally, being Black or Asian were also at higher risk of death compared to white Britons. The big news is actually from today, a report from the Lancet, the journal Lancet, that showed chloroquine and hydroxychloroquine is harmful. They look at 96,000 patients, COVID patients from 671 hospitals in 6 continents. And the bottom line was that patients on chloroquine alone or with another medication, or hydroxychloroquine alone or with another medication, were all more likely to die in the hospital than those who did not. This is the biggest but not the only study that shows harm from these drugs. And my recommendation is that no one with COVID should be on hydroxychloroquine or chloroquine. There are currently 8 potential COVID vaccines in development or being tested. This week, one vaccine manufacturer reported that in phase 1 trial with humans, its vaccines generated antibodies in some of the patients. However, because this went out as a corporate press release and not as a research report, we are unable to assess the validity of the data or what it means. I will finish this update with a concern about the quality of data we are getting from government agencies. The state of Florida fired one of its COVID-19 data scientists. According to the state, the reason was because the scientists were being disruptive and were insubordinate. According to the scientists, it was because the data and the way she was presenting it did not fit with the governor's narrative that it was fine to reopen the state. Perhaps not coincidentally, the number of new COVID cases in Florida yesterday was the highest it has been for 30 days. Several states, including Texas, Virginia, and Vermont, admitted that they were combining the number of tests done for diagnosis using the nasal swab and the antibody test done to document recovery using blood. They are 2 very different types of tests for different purposes. And this seems to me to be an attempt to inflate the number of COVID tests being done by the government. I will finish by saying that it is hard enough to collect, report, and analyze data on the pandemic that is timely and helpful for people and policymakers to plan. But if the data were being deliberately distorted, this makes it almost impossible. So we need to continue to ask for better data and data transparency. Thank you.
Thank you so much, Dr. Nguyen. Very complete briefing. So now we go into the topic of how this pandemic is affecting women. And I have the pleasure to introduce to you Dr. Beatrice Duncan, Policy Advisor, Rule of Law for United Nations Women, who will speak about a briefing that this organization put out regarding the impact of COVID-19 on women, and that we will send to you afterwards. Dr. Duncan, please go ahead.
We know that COVID-19 is aggravating the existing situations of women in which we have found ourselves to be discriminated against across all sectors, be it in the health sector, employment sector, political sector, social sector, and cultural sector. So COVID-19 can be said to be a situation in which women's rights and the advances and progress made in women's rights is actually being set back in a very serious way. So let me give you some concrete examples. We know that about 2.73 women around the world are in lockdown situations in which they are in stay-at-home situations, in quarantine situations, or in curfew situations. This is relegating them to the household or to be in the same environment with their abusers. As a result, we have seen a 3-fold spike in the incidence of intimate partner violence or domestic violence. We are seeing situations in which women are being abused not only by their partners, but sometimes also by their adolescent children. So this is creating a situation of insecurity for women. And because the police force happens to be part of the frontline staff, women are not getting the protection they need from the police instantly. Therefore, in many countries, other ways and means are being devised to enable women to report violence. For example, in Spain, there is an innovation that allows women to go to the pharmacy to signal through either a symbol or a sign that they are being abused. And the police will then either meet them at the pharmacy or ask the women to meet them at home. But I just need you to know that because the police are themselves in the front line of this pandemic, they are not able to respond to the needs of women. But not only the police, the courts as well. Many courts have shut down. Many courts are not sitting. A lot of cases have been put on adjournment or on hold. Many women are not receiving the protection orders that they need. A lot of women are also not receiving either maintenance for themselves or maintenance for their children. So there are a lot of judicial suspensions all over the world, thereby curtailing the protection and enforcement of rights that women need. I also need to say that because women find themselves at home at least 99.9% of the time, now we see that in 177 countries, there are school closures. And this is affecting 1.66 billion children all over the world. Who is bearing the brunt of taking care of the children? Who is bearing the brunt of taking care of the online school sessions? It's the women. And in fact, women bear the brunt of unpaid care work 3 times more than men. In the sphere of employment, we also see that more resources are being diverted to the health sector, and rightly so. That's very important. But as a result of that, women are not receiving the necessary services they need around sexual and reproductive health. This is very worrying because in a lot of countries, the rates of maternal mortality, I'm glad we have a doctor on the call, rates of maternal mortality in several countries for women, it tends to be very, very high. And in fact, in the Western world, including the United States, maternal mortality rates are higher for women of ethnic minorities. So this is something that we need to bear in mind. And on top of all this, women's organizations that are offering shelters for women are either closed or underfunded, and therefore cannot meet the high demand. In the United States and in many other parts of the West, we tend to think of violence against women only in terms of domestic violence. But in other parts of the world, there are also harmful practices that are taking place, such as female genital mutilation, early marriage of girls, even in the United States, below the age of 18, where the law actually permits parents to give off their daughters in marriage. And at UN Women, we believe that because the security agencies are no longer on the alert, because there's been a breakdown of law and order and the rule of law, that there is a spike in some of these harmful traditional practices. And especially as it relates to early marriage, we believe that it needs to be connected to the overall framework of public health, because early marriage and FGM also impact upon the health of girls. So another important area I wish to mention is that as a result of the pandemic, 144,000 women all over the world have been widowed. So this means that they are now single parents. This means that if they live in a country where the right to inherit is not recognized for women and girls, that they will not receive the necessary protection they deserve. So just to give you a snippet, at least 1 in 5 women all over the world do not have the right to inherit in the same way as men. So these 144,000 widows around the world could be going through a phase of lack of protection from the state.
We're going to move on to our next guest. And we're very happy to have with us Dr. C. Nicole Mason, President and Chief Executive Officer of the Institute for Women's Policy Research.
So this is a really unprecedented time, and I feel we keep saying it, but it really is an extraordinary moment, and one that will define us for generations to come. Just a couple months ago, we were celebrating the gains that women had made in the U.S. in the workforce. At the time, they were about 51% of the labor force. And at the time when we were reporting on those numbers, we knew that there was something underneath the numbers, that even though women were in the workforce in record numbers, many women and families were still struggling to make ends meet, and that measuring the economy by high levels of low levels of unemployment in the stock market didn't quite capture the day-to-day realities of many women and families. And COVID-19 has really exposed some of the fragility of our economic and social and political systems. And many of those gains that we were just talking about or celebrating just a few months ago have all been about wiped out. Women now, because of high unemployment, make up about 47% of individuals in the workforce. The reason for this is that over the last month and a half, the U.S. economy has shed more than 30 million jobs or had jobless claims, and women have made up a disproportionate amount of those claims or those job losses because of their overrepresentation in the service sector, in healthcare, education, leisure, and hospitality. And what that has meant is that now the unemployment rate for women in the U.S., for example, hovers around 15%. And that figure was just 3% a month and a half ago. So COVID-19 and the pandemic has had a devastating impact on, working women and their families. The next thing I want to talk a little bit about in terms of the impact of COVID-19 on women and families is something that Dr. Duncan mentioned just recently, but about the burden of care on women during the pandemic. So what is true is that because of stay-at-home orders, many women have lost access to their daycare or childcare, and as many of you know, across the globe, schools have closed down. But what that has meant is that women are placed in a dual role of not only primary caregiver, but also responsible for schooling for their children, and also holding down continuing to work. So in the U.S., about 30% of workers can work from home, but women who are working from home are also continuing their 40-hour work week and have, to maintain productivity, but also primarily responsible for caretaking demands. And so this has placed an undue and unnecessary burden upon women. And for women who cannot work from home or who are now considered essential workers, many workers, again, who are in the service sector, are having to make really tough choices between being able to take care of their families and make a living. And this is exacerbated for many single mothers who have children under the age of 18 and are the primary breadwinners for their family. So about more than 3 million women are primary wage earners in their families, meaning they contribute more than 40% of their income to their families. And so for these workers, especially these workers who are in lower wage jobs, it puts them in a very precarious situation. And many of them were struggling before the pandemic took hold. And a related point that I would like to make is around wage inequality and wage gap and the pay gap. So what we know is that women were already earning less than their male counterparts in many sectors, and what that means in related to the pandemic is that because women were making and earning less before the pandemic, it means that they also had less money in savings to ride out an economic downturn such as the one that we're facing, not only in the US, but globally. And also it translates into real terms in terms of being able to provide food for families and housing and other things that have become precarious during the pandemic. The other point that I'd like to make is that related to gender-based violence and violence against women during COVID-19. As Dr. Duncan alluded to, this is a really unprecedented moment, and just as we're seeing the impact of the erosion of the social safety net and economic vulnerability of families, we also knew that before the pandemic, women who were experiencing gender-based violence had lacked systems and supports, and that has only been exacerbated since the start of the pandemic because of the lack of support services and shelter and emergency beds for families, for women who are experiencing violence. So when we put all this together, the economic vulnerability, the wage inequality, the increase in gender-based violence, what I think is important for us to know is that women have been disproportionately impacted by the pandemic and COVID-19, not only here in the US, but globally, but that they will have a harder time in terms of thinking about recovery. So as I noted earlier, women have lost a disproportionate number of jobs, but many of those jobs will not be coming back. So there's not going to be a one-for-one replacement for the jobs that have been lost. The second thing I think is really important for us to note in terms of thinking about recovery and making sure that we take into consideration the particular needs of women and families is that, because many daycare centers in the US have already said that they could not last more than 2 months without families coming to their centers. And so what we know is many of those daycare centers or those resources that families depended upon before the pandemic will have disappeared or will not be available after the pandemic. And so when stay-at-home orders are lifted, but parents, women specifically, have no place to take their kids for care, and schools remain closed because of the threat of the pandemic, women will really be bereft and not have the supports and systems they need to stay in the labor market or to be able to provide for their families. So when I think about the path and the recovery and what we should be doing, I'm thinking about making sure that women have the social supports that they need to be able to not only re-enter the workforce, but stay there, and making sure that employer practices are also enhanced so that women can have flexibility in terms of their schedule, as well as addressing their childcare needs.
Thank you so much, Dr. Mason. We appreciate you being with us. And we'll go immediately to Dr. Estela Rivero, Research Associate with Notre Dame's Pult Institute for Global Development.
So we know that time is one of our most precious resources. I mean, everything we are, in essence, is a result of how we use our time, right? Unfortunately, we've been hearing throughout the world, the demands on women's times are far greater than those on men's, as they are more responsible for unpaid work and caregiving. These responsibilities limit women's opportunities for engaging in paid economic activities, and which provide them with financial independence and leverage for bargaining power in household decisions. So this really has important consequences on women's both economic and power. So additionally, by having to juggle multiple roles, women usually see their leisure and their resting time affected. So this has effects on their mental health as well. And this has further consequences. The point that is important to bring up today is that research suggests that COVID-19 and lockdown policies have exacerbated these already pre-existing disparities. Women are more likely to pick up the additional workload that as children are homeschooled, as members of the household become ill, and as family members spend more time at home and then housework increases. In the time that I have left, I will show you why this is the case using information from Counting Women's Work, which is a project that documents women's contribution to the paid and the unpaid economy. And by this, I mean housework and care throughout the world. I will also talk a little about a research that I am currently conducting in Mexico, which can help us understand some of the potential consequences of the lockdown on women's and men's times. The next, please. In this slide, I show the number of hours per week that women and men in the US, so this is something most of you are familiar with, spend on unpaid care work and paid work throughout their lifetime. We have age on the x-axis, and then we have the number of hours per week on the y-axis or the vertical axis. And by unpaid care work, I mean direct care for children, for elders, ill household members, and other household members. I also include housework, household maintenance, and management within the unpaid care work area that is in blue. What is really important to notice here is that in the US, women spend more time than men on unpaid care work. I was saying the blue areas. Women are on the left-hand side, men are on the right-hand side. And this happens throughout all ages. We can see that the blue area for women is higher at all ages. The other thing is that men spend more time on paid activities, which is the yellow area. But also, if we compare the sum of both the economic activity and the unpaid care work, it turns out that women work more hours than men. I mean, we need to consider, and this is something very important, we need to start considering care work as work. And if we take both economic, or what is usually considered as economic work, and care work together, women work more hours than men in the US. Next, please. This shows the same indicators, in this case for Ghana and Mexico. And we can see that the disparities vary. The amount of work that women and men do varies as well across countries. But in all cases, both in Ghana and in Mexico, women work more hours on unpaid care work. We have the same pattern of this blue area being higher throughout all ages. And we also have that women spend less hours than men on unpaid care. The next one, please.
Dr. Rivero, if you can quicken this a couple more minutes, we are running over.
Oh, I thought I was going fast. Okay, this is just to show you that these disparities hold across all throughout the world, both in developed and developing countries. Blue lines is market work. I'm sorry, green is the market. Blue is unpaid care work. And I want you to focus on the blue, on the purple lines. And the purple lines are the total work excess that women do. And in all countries, being it US, Holland, Italy, Spain, Mexico, Vietnam, everywhere, women work more hours in total than men. The next one, please. So how do these inequalities change with COVID-19? I mean, to answer this question, we would need comparable data before, during, and after the pandemic, because the pandemic is really changing many things within the household. We do not have that. However, an analysis of existing data and how things change when there are out-of-school children and ill household members in the household can give us an idea of what might be the minimum consequences. I did that for the case of Mexico. This table is showing a comparison of men and women who are married and who have children and ill household members in their home against those that don't. And what happens is that when there are out-of-school children, women's hours of direct care increases 3 hours per week, their supervision time increases 3 hours per week, and they also decrease their paid work. So these changes are even more, are even larger when we are talking of ill household members which need intensive care. We can see that the number of hours of direct care for women increased 10 hours per week, which is really a large amount. I mean, that is equivalent to almost half a paid time work. They also increase their hours of supervision, they decrease their paid work, but, and more importantly, they decrease their hours of sleep and leisure. So this is having an impact on how they spend their time. The role shows the changes in men. When there are ill household members, men contribute somewhat, but they do much less than women.
So we're going to Dr. Kirsten Swinth, Professor of History of Fordham University, who is with us to talk a little bit about how other pandemics in this century have affected women.
Hi, good afternoon. Thanks so much for having me, everybody. I'm really glad to be here. So I want to talk about what history teaches us about crisis and women's experiences and opportunities, kind of answering the question, does crisis open the door to advances for women or greater equity? And my answer is a qualified yes. So I'm going to talk about two moments of crisis in the 20th century US, taking on the sense of coronavirus as a crisis, as one that's both medical and economic. I want to talk about the 1918-1919 Spanish Flu Epidemic that killed 675,000 Americans, and the 1930s Great Depression, where unemployment hit levels like those we are seeing today in the US. And I'll conclude with a brief assessment of what this past might teach us about looking forward. So women were pulled into the 1918-1919 Spanish flu pandemic in two ways. First of all, through existing networks of organized women who had already been involved in cleaning up and improving cities in the US as part of progressive reform of the early 20th century. More significantly, however, women played a huge role in nursing those who became sick from the flu. It's comparable to the ways that women today are on the front lines of nursing in hospitals and nursing homes and as home health aides. Nursing was then, as it is now, a profession dominated by women. And in the early 1900s, nursing was in the midst of developing modern professional standards of multi-year hospital-based training according to the latest principles of scientific medicine. By 1910, there were 1,000 training schools across the United States for women, and it was one of the few professions that was open to women in this period, and nurses felt extraordinary pride in their status and skill. As the flu pandemic spread across the US, tens of thousands of nurses were organized by the American Red Cross into two distinct networks. The first is the Army Nurse Corps, which brought on board about 24,000 nurses working for the military. And the second is home defense nurses, nurses who were organized by the American Red Cross to work domestically. Segregation was standard practice among nurses, so Black nurses served Black hospitals and Black communities. Occasionally in the pandemic, they were asked to serve white communities. Carnegie Steel, for example, in Pittsburgh, stooped to hiring 16 Black nurses to care for its employees. Historian Marion Moser Jones has also shown how desperation finally led the military to allow 18 Black nurses into service in the Army Nurse Corps, and they would be the only women of color allowed to serve in the Army Nurse Corps. Those 18 women nursed in both Black and white wards. Nurses in the 1918 and 1919 pandemic were actually more effective than doctors. They provided the essential supportive care that patients needed, keeping patients warm, feeding and bathing them, giving them the palliative care that was essential. Doctors had few remedies and no heroic interventions. So this, I think, is a sharp contrast to the intubations and other interventions that we've seen today and kind of have been at the center of the news. In fact, the 1918-19 flu pandemic was a huge blow to male-led modern medicine and its faith in science to cure infectious diseases. Nurses, however, recalled their experience during the pandemic more positively because they felt that they had provided essential aid and care in a time of crisis. Their professionalism was recognized and valorized. One nurse remembered the pandemic as a time most horrible and yet a beautiful experience. There are two legacies of women's leadership as nurses during the crisis that I think are worth paying attention to. First of all, the 18 African-American women who served in the Army Nursing Corps were profiled as civil rights heroines in Black communities and widely lauded in Black publications. They were earlier barrier breakers and civil rights leaders. More broadly, nurses were idealized as heroines after, through the pandemic and also through their work for the US war effort during World War I. Remember that the flu pandemic and World War I are very much overlapping endeavors. Their service, nurses' service, was often cited in support of women's suffrage. The battle for the right, for women's right to vote in the United States was in full swing, mobilizing millions of women across the country. And the battle for the 19th Amendment actually continued across the flu pandemic, although women's activists had to alter their tactics. They had to shift from large-scale rallies. For example, they had planned a train tour of previously arrested suffrage protesters, and instead they relied upon the millions of women that they had actually already organized in a highly efficient state and local network to go door to door and distribute pamphlets and advocate for the suffrage amendment. Gratitude for women's service during the war as nurses and as basic volunteers during the pandemic played a role in broadening support in 1918 state referenda on suffrage and ultimately in passing the 19th Amendment out of Congress and for its ratification in 1920. So women faced severe unemployment in the 1930s, although unemployed women remained relatively invisible. So I think unemployment in the 30s and the Depression is different than it is today for women. Women weren't actually supposed to be on the job in the first place because, after all, the theory was an employed woman was taking a job away from a man, and in theory, every woman should have a man to support her. So many states and localities and the federal governments issued bars to married women's employment. Employed women during the 30s faced incredible hostility, and that hostility fell particularly hard on women of color. And I could say more about that, but I'll set that to the side. Women were also drawn more broadly into the decade surge of labor activism. Female union membership in the 1930s increased to 300%. So I think this is an important thing to think about in the face of severe unemployment, what kinds of responses and ways that women are drawn into activism. But equally significant to labor unions, and I think deeply relevant to today's experience, was a wave of housewife-led militancy and consumer strikes. Historian Annalise Orlick calls this organizing by housewives a nationwide uprising by mothers against the high cost of living. So you had mothers in New York City, Seattle, Richmond, Virginia, Los Angeles, all across the country. You had immigrant and native-born mothers, Black and white mothers, Jewish and Christian mothers. This was truly a sort of broad-based nationwide movement. These women staged anti-eviction protests, consumer boycotts, rent strikes, protests for better education and affordable public housing. They created large-scale barter networks where people could trade food for labor. They lobbied for legislation to regulate the costs of staple foods and housing. These activists thought that government should regulate prices as well as wages in order to bring down the high cost of living so that all Americans could afford decent housing and basic staples. So in 1935, I'm going to give you one quick example. Housewife activists organized a nationwide meat boycott where they fought price gouging for meat. They burned down warehouses where suppliers were hoarding meat to inflate prices, and they lobbied legislators to establish price controls on meat as a basic staple of life. This tradition of a housewife-led movement against the high cost of living lasted into the early 1950s. One final and kind of quick and quirky point about the 1930s that I think is interesting in light of discussion today about COVID divorces or COVID babies was the widespread use of contraception in the 1930s and its legalization in 1936 for married couples. And it's in the 1930s that we see this kind of bottoming out of the birth rate that set the stage for the baby boom in the 1940s. So boomers are, they come in the next generation. So quickly, just a few words about the lessons about that I take about where we go from here on women's equality and rights. And I'm a little hopeful. I think that it's possible that valorizing nurses and female essential workers could be leveraged to advance crucial aims of better pay and improved working conditions in caring professions. I think that fears of getting sick on the job, along with their anger at terrible pay, may bolster unionization for frontline low-paid service workers where women predominate. We are already seeing calls for organizing rent strikes, campaigns for affordable housing, and other ways to reduce the cost of living, as well as barter networks that parallel those of the 1930s. I'll just say quick bottom line about all of my examples and the analogy to the present is that nothing happens automatically, that crises in and of themselves don't lead to greater change or advancement for women's equity. Rather, change that produces equity happens because of organized activism in response to gaping inadequacies of the system that crisis exposes.
We want to go to Mimi Lind, Venice Family Clinic Directors of Behavioral Health and Domestic Violence Services. And she can give us a little bit of the view from the ground, from a clinic here in LA, and what they're seeing in terms of, access to services, domestic violence, and other health situations.
Domestic violence is the use of many types of abuse, physical, sexual, financial, using the kids, and emotional, name-calling, shaming, and using social media to hold power and control over a partner or an ex-partner. So that's what we're talking about, those dynamics. So that's domestic violence definition. And unfortunately, what I'm suspecting, because I haven't seen any great statistics right now, and maybe a lot of the researchers on the call have, but we haven't seen necessarily an increase in the calls to hotlines that I've seen, but I think there's big reasons for that. At our program, for example, we have lost a lot of the opportunities for some of the informal ways that we are able to identify victims or survivors of domestic violence. One of them, for example, is when you come to the clinic, every woman, right now it's just women, we ask from 12 years old and up once a year about domestic violence in their lives right now or in their past. And when people are not coming into the clinic, it's much harder to ask those questions. Now we've moved to screening people over the phone, but because of lockdown, there might be sitting right next to their perpetrators, or the perpetrator asks for them to put everything on speaker so they can hear what's being asked. So a lot of opportunity is lost in that way. The other thing is that we know that the stronger the relationship we have with the patient, the more they'll open up about. And that's true for all of us with our provider. Think of the things that you might tell a provider, your own provider, that you might not tell the person taking their place for the day. And so when you have a relationship with someone at the clinic, and it might not be your doctor or your nurse practitioner, it might be the person checking you out. It might be the security guard that you've been seeing for 20 years. Our clinic's been around for 50 years, so we have long-term relationships with our clinic, with our patients. We've lost some of those informal connections where the person might be that one moment where they feel like opening up or telling the truth. The other day I was talking to a victim on the phone, and she called for the first time in many years and said, I can't take it anymore. My husband lost his job. He's home all the time, and he's regularly raping me in bed while I'm sleeping. And he had a night job, and so now he's home. And so that time for her that was a peaceful, safe time is no longer. We know that there was a study at UCLA years ago that said that the increases of domestic violence increase with unemployment. And so everything we've talked about today speaks to that. And there were a lot of questions today about the different cultural experiences, differences of rural and urban. And we know that domestic violence is a pandemic. And I don't mean to misuse that word, but it is. It's across all cultures, all counties, all small villages and huge cities. I don't know of any culture that hasn't experienced it, or any religion. It's across the board. And I've worked in Boston, in Costa Rica, I've lived in France, I've lived in Hawaii and Los Angeles, and everywhere I go, I hear about communities and domestic violence. And so it truly is cross-cultural. I think the only thing that's different across cultures is maybe the way they do it. Some cultures might do public shaming more. Some cultures might use more physical abuse. But across the board, there's a lot of domestic violence everywhere. So I'm gonna kind of stop because we have very little time. I have lots to say, but let me just add two good things that are happening. In Los Angeles, you can continue to get a restraining order at the courts. So even though the courts are closed for everything, you can still get a restraining order. The other thing about specific to Los Angeles is when you call a domestic violence hotline, they can help you get into a motel. A lot of the shelters now have a voucher program where they can't take you into their shelter, but they can take you, they can try to help you get in a motel if there's still space available. So there's a little bit of light at the end of the tunnel with some of the beautiful things that are happening and some of the ways that women's safety, because the vast majority of victims of domestic violence are women. And so there are some ways that women are being seen. So thank you.